अगर आप रेडियोलॉजी रेजिडेंसी में आए हो, कितने भी धुरंधर हो, यू हैव टू स्टार्ट फ्रॉम जीरो। ठीक है, जितने मर्जी बड़े टॉपर हो, जितने मर्जी गोल्ड मेडल्स लिए हैं, you have to start from zero.
What study strategy works best for the resident?
You cannot study all the theory in 3 or 6 months. So you have to study based on the cases what you see on day-to-day basis. So you do one case and which you think needs to be learned, study about that case, come back the next day and then report it. So this is, we call it as case-based learning.
If somebody asks me, now first year residents want to know where to do fetal medicine fellowship. That is not the right approach. Join a senior residency at a good government college or where patient burden is high. Then choose what you love. Radiology is training your eyes to see clearly and thinking mind systematically throughout practice.
Okay, one very bad habit I have noticed with the residents is some of the residents, they avoid reporting difficult cases. So I suggest please do not avoid reporting difficult cases because someday you will get caught.
So hello everyone, welcome to Salaah Shots podcast, a space where we talk about the journeys that textbook never teach. I am Dr. Pushp and my mission is simple, to make medical careers less confusing, less lonely and more guided. So today we are starting something very special, Radiology Residency, a real talk. Radiology is often seen as a comfortable branch, AC rooms, screens, no emergency calls. But every radiology resident knows the real battle is silent, internal and the daily. And to guide us through this reality, we have not one, but the two incredible guests, Dr. Gursimran, MSK Radiology Specialist, and someone who has walked the journey from confused resident to confident specialist, and Dr. Ekta, consultant radiologist. So bringing not just professional wisdom, but the human side of residency, they are partners in life, and today, partners in sharing the truth with you. So if you are a radiology resident or planning to join the radiology or simply curious about what happens behind the reporting screen, so this episode is for you. So let's begin. Dr. Gursimran and Dr. Ekta, welcome to Salaah Shots.
Thank you very much.
Thank you, sir.
Yeah, so before radiology, before degrees, who are you as a people?
Hi, I'm Dr. Gursimran Singh Anand. I'm MBBS, MD Radio Diagnosis. From the starting, I've been a very curious person who likes to do things well. Since my 12th standard, during my MBBS, I've been a topper throughout my career. But over that curiosity has shifted from academics to imaging, and now has shifted to teaching as well. Okay. What I genuinely love is actually breaking down complex concepts into very simple practical ideas. And for the same thing, for the past 2 years, I've been a radiology educator at a national level platform for the past 2 years.
Hello, everyone. I am Dr. Ekta Mishra. I am MBBS MD Radio Diagnosis with special interest in fetal medicine. So my area of specialization is fetal medicine. Beyond that, I do general radiology. So same, I was also very nerdy throughout toppers, CBSE 12th topper, and then getting MBBS and MD radio diagnosis in the first attempt. I also made to CMS All India rank 16. And that was the confusion time. Now it's like you have very good rank and you can get any cadre you want. And you are getting radio diagnosis. Very tough choices. And you all know I took radio diagnosis. So if you bag multiple things, confusion comes. So yes, I did all the three. And beyond that, I chose fetal medicine as a specialization. So what I realized during this journey is that staying focused and not giving up, that attitude converts you from resident to consultant.
Okay, so quick one-liner.
I enjoy learning and sharing knowledge. Yes.
So one quick liner from each of you. Radiology residency in one honest sentence.
So according to me, the radiology residency is actually very humbling. अगर हिंदी में बोला जाए तो आप कितने भी धुरंधर हो, you have to start from zero. ठीक है, जितने मर्जी बड़े टॉपर हो, जितने मर्जी गोल्ड मेडल्स लिए हैं, अगर आप रेडियोलॉजी रेजिडेंसी में आए हो, you have to start from zero. Okay? That is even in one line I have to say. So ये धुरंधर तक से बिगिनर तक का सफर है. ठीक है, दोबारा.
Radiology is training your eyes to see clearly and thinking mind systematically throughout practice. So that's my one-liner.
So मतलब आप दोनों लोग पार्टनर, तो आप लोग से क्वेश्चन पूछा था कि सेम ब्रांच सेम प्रोफेसर, तो did that help or complicate life initially?
Initially it was complicating. Okay, थोड़ा सा ego clash भी था, but बाद में आके it combined into a strength.
Yes. So there is always, you always have different opinions on the same thing. The same, when you start discussing, if you feel that this should be a better differential, a lot of discussion, the academic ones. And that's why we chose different specialties. So I took fetal medicine and he chose MSK.
Okay.
So we sorted it.
So if we'll talk about like day one of radiology residency, मतलब कोई अगर junior को focus करना हो mainly किन चीजों पे, तो will it be machine, anatomy or reporting format? Is it normal to feel completely lost in first few months?
In the starting, you have to focus on anatomy first. ठीक है, अगर मैं एक एग्जांपल लेके चलूं, तो जिम भी जब हम स्टार्ट करते हैं, कोई एक्सरसाइज स्टार्ट करते हो, you have to first learn the correct form. उसके बाद आप स्ट्रेंथ बाकी उस पर फोकस करते हो कि मुझे वेट बढ़ाना है. सिमिलरली रेडियोलॉजी में यू हैव टू स्टार्ट विद द एनाटॉमी. यू हैव टू बी वेरी क्लियर विद व्हाट इज एक्चुअली नॉर्मल, तभी आप एबनॉर्मल बता पाएंगे. इनिशियली कंफ्यूजिंग रहता है फॉर द रेजिडेंट्स, ओके, बिकॉज लर्निंग कर्व इज टू मच. यू हैव टू शिफ्ट फ्रॉम medicine to, you have to learn actually machines as well, and how the structures in the body actually look on these images. Exposure to radiology in MBBS is actually very less, so you are meant to get confused on the first day of radiology residency. That is actually absolutely normal. अगर आप confused नहीं हो तो कुछ गड़बड़ है.
तो मतलब अगर फर्स्ट ईयर रेसिडेंट को देखा जाए, अगर वो जो अभी रेसिडेंसी ज्वाइन करने वाले हैं, तो उनके लिए मतलब एज ए लॉन्ग टर्म, टू अवॉइड ए लॉन्ग टर्म स्ट्रगल, क्या क्या हैबिट्स उनको डेवलप करना चाहिए?
Simple words. Kak cheshta bako dhyanam, swan nidra tathaiva cha, alpahari griha tyagi, vidyarthi pancha lakshana. Very short. So this is applicable to all residencies and in radiology especially, because it's as if you are changing the line. It's completely different from clinical branches. So first of all, discipline. Every day nobody is coming to motivate you. So discipline over motivation is very important. And build consistency. You have to learn new every day. There are multiple modalities, multiple things to learn. So these 5 habits are very important.
So if we'll talk about the reading theory from the standard textbook as compared to the hands-on reporting and observation, so how much theory we have to focus on?
So theory is something which will help you learn the basic first. You should know something, then only your eyes will see that problem. So theory is 80%, especially for the first years. The moment you know basics, and after that you will start applying the knowledge. So theory is definitely very important.
So the same question for
important as,
yeah,
theory is as important as a stick to a blind person. अगर स्टिक नहीं है तो चाहे जितना मर्जी सुनता है कि उस हिसाब से कर लूंगा, मैं जैसे मर्जी कर लूंगा, बट स्टिक इज वेरी इंपॉर्टेंट. दैट विल गाइड यू थ्रू आउट द कोर्स.
Okay. The same question from both of you. Like, how did each of you personally build confidence when everything felt confusing early on?
Okay. In the starting, I accepted confusion as a part of the learning. Okay. In my story, I'll tell you, during my MBBS days, there's a subject we called as pathology. And in that, we have histology slides that we have to identify under the microscope. Okay. Personally, I was very poor at identifying images. Okay. In spite of being a university topper, everything, I got 0 in the histology slides. Okay. So from the starting point, I was very poor in imaging. Okay. So actually, this branch was not built for me. But with repetition and continued practice, I was able to get over that. And because of that repetition, continued practice, daily reporting, today I'm a national level educator in radiology. So that repetition has helped me. Okay, it's not an individual intelligence thing. You have to do it on a day-to-day basis, again and again, again and again. So as to get perfect at it. Okay? It's not something like individual brilliance at one day. you read something and you report that, and then you become a durandar.
Exactly.
It's a slow process.
My point of view is build strong basics first. If your basics are strong, then only building will stand. So first is that. Second is, remember, radiology is a branch which is going to solve problems of clinician. You are trying to avoid their confusion. So whatever differential they have in their mind, our work is to clarify it, that this is the first differential. So building strong basics will help us do the differential. Second thing is application of all the 19 subjects in that single report. It's very important, so that correlation is there. And then the most important thing is following the checklist. Basically, to avoid confusion, you have to have a pattern. So if you're doing a scan and you see one abnormality, you won't leave other organs. So follow the checklist clearly in the same order. And as sir pointed out, repeat the same process, develop pattern recognition and crisp conclusions to help our fellows.
Yeah, so as you both told about the mistakes and confusions. So what common mistakes do new MD and DNB residents make that later become hard habits to break?
The first and foremost is they stick on to a finding and they leave the rest. So not following a checklist or format. For example, this is a personal anecdote. So my friend found a ureteric calculus. So surgeon resident on call was asking, patient is having very acute pain on right side. Ureteric calculus was diagnosed, but missed on appendix. It was appendicitis case also. Concomitant findings can happen. Always follow the format. Check all the organs in spite of getting a positive finding. So first. Second, they don't revise. They read everything and then don't revise, especially the things that they have missed. So if you are reporting a case and you missed a finding, it should always be in your back of mind why I missed that. So keep revising and develop an approach. Third and most important is don't compare yourself with your peers or third years. First year resident starts thinking that why my third year was able to pick it in 5 minutes and I could not. That is a wrong approach. You cannot compare yourself or your peer. It will lead to anxiety and loss of confidence. So keep it simple, practice daily, read daily. You are in your own battle. The competition is already over in NEET PG exam. So that's very important.
One more thing I would like to add. Okay, one very bad habit I have noticed with the residents is some of the residents, they avoid reporting difficult cases. Okay. There are cases which are very simple and there are cases which demand some academic knowledge. So you have to go home and study about that case. So there are residents who keep avoiding these difficult cases in their residency and they carry this habit even to the practice. Okay. So what they do is they pass these difficult cases to their colleagues and they keep on doing this throughout their whole life. So I suggest please do not avoid reporting difficult cases.
Don't run away.
Don't run away.
There's no escape.
Someday you will get caught.
Yes.
When nobody will be there, you will have to report that case.
Yes.
So
start that practice from the residency.
Right.
So when seniors are doing most of the reporting, how should juniors actively learn instead of just watching? What they should keep in mind? Like you told us some technical things you need to keep check on these. So what they have to keep check on that?
So in our college, what used to be done is the first year was taking history. So for 1 year, we were taking history. So after passing NEET PG with such a good rank, we used to feel that, are we stupid who is just taking history, not learning anything, not doing ultrasound, not doing CT reporting or MRI reporting. I'm doing the same work as medicine resident is doing the same work. So that time my senior told me it is not a passive history taking. So what as a radiology resident I was supposed to do at that time was to take proper history and do acquisition of case accordingly. So whatever was being suspected, if something could be done additionally, should be added in that acquisition. Second thing, everything is a learning opportunity. So when the case is being done, I was the one who was looking at that case as a first year. So when it is being done, to avoid any artifacts or any complication, any contrast reaction. So that is a learning opportunity. So the moment the case is being acquired, I have to make a provisional diagnosis in my brain with clinical history provided to me. And after the reporting is done, I can check whether what I was thinking was right or not. So that is about diagnosis. In the second year, you can start writing the reports on your own if you're not able to report that case independently, and then check your report with the final report that was given to the patient. Then you will also learn the description. So compare your thinking with theirs. What the senior is reporting, are you able to think on the same lines? That will help you develop an approach to a particular case. So pattern recognition is very important in radiology. In all the fields, it's important. So you have to develop that thinking and pattern recognition, and that will come with every case, be it first year or third year. So that we need to work upon.
Okay. So if you talk about speed versus accuracy, so what matters more early on? When should speed start improving?
Accuracy is the most important thing initially. First, you have to get the report correct, the diagnosis correct. Okay. Once you start recognizing the patterns, speed will automatically come. Okay. In the residency, you are not liable for any reports. Nobody will ask you why you have missed this finding, because you are there in the residency to miss the findings.
Exactly.
So that you don't miss these findings when you start reporting independently. Okay. So focus on accuracy first. Okay. Speed will automatically come on.
So accuracy is of utmost importance. Speed will definitely come, but it will not beat accuracy. You cannot afford to miss a finding. So always remember, there is no race who reports most cases.
So one funny question from both of you, like if you recall your residency, so be honest and tell how many times in first month did you zoom in or zoom out, adjust window, and still think, ye normal hai ya pathology?
I'll start with the answer. Honestly, I did not like anatomy. So first of all, I was at a disadvantage of choosing radiology, because radiology 90% is anatomy. So I was the one who would think whether this bone is medial or lateral. If you ask me, is tibia medial? I would take a minute to think about it. So that was the level of anatomy. So yes, I used to get lots of time zoomed out whether this is a normal finding. Because when you are looking at a case, beyond a normal anatomy, there are variants. So they confused me a lot. I think sir had an advantage because he was a gold medalist in anatomy. He definitely had an advantage over me. So initial period was very confusing.
Okay.
So although I was a gold medalist, but since I was very poor at imaging initially.
Everybody had their disadvantages.
It took me at least 6 to 7 months to get in the sense of radiology. At least 6 to 7 months.
So it's normal.
To get the hang of radiology.
ऐसा लगता है ना कि यार ऐसा लगता है कि इतना पढ़ के आया हूँ तभी भी कुछ समझ में नहीं आ रहा.
बिल्कुल. So those who are thinking कि बहुत अच्छा रैंक लाए, रेडियोलॉजी मिल गई है, अब लाइफ सेट है, बिग मिस्टेक.
ये एक रहता है ना यार, मैं टॉपर हूँ, मुझे रेडियोलॉजी मिल गया, अब तो रेडियोलॉजी मिल गया, अब तो मैं सेट, बस अब कुछ करना ही नहीं मुझे.
Then you will know, you will get confused. How does water look on CT, ultrasound, MRI, and in real, you will forget everything. It's very difficult.
So, everything in the shades of grey.
So how did your reporting style changes once you become directly accountable to clinicians and patients?
We become very careful with the words.
Yes.
Because each and every word now has consequences. When you're signing the report below, okay, each and every word which is there in the report will guide the treatment of the patient. And since we will be always accountable, because each of our reports are signed, okay, and each of our cases are there in the PACS systems. So anybody can assess those cases and review that. Okay. You cannot re-review the clinical features of the patient or symptoms of the patient that the person has asked. But our thing, each and every word is accounted. So you have to be very careful whatever words you're writing in the report.
Everything has medical legal implications, basically.
Yes.
And especially with fetal medicine, you cannot escape. Even a single scan, you cannot skip.
You cannot let your guards down even for a single second.
Yes. So how did my reporting change? When I was a resident, I used to I like to write 2 pages of comprehensive report. It is touching that organ with this angle of contact and all those description. Now, but practicing, I realize my clinical friends are interested to know very few things, the clinically relevant questions. So report comes down, it becomes narrowed to cater to the clinical question.
So if you go back to your residency time and you want to answer this question, like how so junior residents communicate with the clinicians when they are not fully confident?
So basically communication is the thing which everybody makes fun of, for radiologists especially, that there is no patient communication and they don't know how to talk. And I tell you, it is 100% true also. We don't really know how to talk because we are never made to talk in residency period. So that is a skill that needs to be worked upon. We should be able to interact with our fellow clinicians to know what clinical differentials they have in their mind, and then actively look for those in the scan. Look for points that prove or disagree with the diagnosis. Diagnosis can be completely different, but whatever was the initial plan should be answered. So communication is the key. Then there are few cases where the findings are very gray zone. They are not very clear. They're equivocal basically. In those cases also, you should be descriptive and give all the findings and communicate in such a manner that it helps the clinician rather than confusing him and telling him multiple things. So communication is the key.
Okay.
So always guide the clinician.
Yeah.
Not misguide him.
Yeah, we have seen so many reports that correlate clinically.
Yes.
And the joke goes with radiologists always. So
what soft skills matter most in radiology, but are rarely taught during your residency?
One is the clinical communication, which we just talked about, and some things is you have to learn to handle criticism. Even if you are right, sometimes you will be criticized.
okay.
So you have to learn to handle criticism as a radiology resident.
And I believe decision making is very important. Giving 10 possible differentials is not going to help anyone. So if your differentials are inflammation, trauma, malignancy, and nature, it is not going to help anyone. So decision making is very important, and you should be very crisp, focused. So I think that is another important thing. So everything will come together if your basics are clear, knowledge is appropriate, communication skill is good, and ability to report. So being on the desk, everything will help to this.
So now you both are consultants. So what was the biggest gap between the residency training and the real world independent practice?
I would tell, especially the training part, it's about fetal medicine. The ultrasounds of fetal medicine, because we have a lot of litigations involved, the PNDT Act comes in. So usually the senior residents and consultants do the ultrasound, and the moment residents get time, I was a resident, whenever we got time and we thought the seniors are doing it, we used to be careless and not focus on it. But the moment you come in private practice or do an independent case reporting, the first thing that comes to reporting is doing fetal cases. So that's a major gap, where you did not practice in residency and you're expected to do the scans on the day one. So I think that is something which residents should focus from very beginning, the training. Nothing has to be skipped. Everything needs to be covered in that 3 years. And believe me, 3 years is a very short time.
And even in spite of being a MSK radiology specialist, I am made to do the fetal scans till now.
So
because the centers, they usually run on fetal scans only. Okay. The most amount of burden in radiology is for the fetal scans only.
So nothing can be
survive
skipped
without fetal scans.
Yes.
Okay. So many of residents thought about that. Just we have taken this radiology, and now our life will be chill after completing our residency. So what will be the message for them?
First of all, it's very good. Hearty congratulations to all my friends who are coming to radiology. But let's break the myth. It is just like learning Chinese. First of all, you are learning a completely different way of medicine, practicing medicine. All machines are new. Your language of reporting changes. when to use hyperdensity, hyperintensity, hypoecogenicity. It's very difficult. So you are learning something very new. Second thing, all the 19 subjects needs to be used. Your surgery friend will be reading only surgery, but you are reading gynae, pediatrics, medicine, even PSM, everything you are reading. So it's a very nerdy branch. You have to read everything. So if you love reading, join. After that, tech savvy, you need to know how to use all the systems. So if you are tech blind, then it will be little difficult. So that is also very important. It's not very rosy as is depicted on social medias, but it is not that bad either.
So now we'll talk about the study strategy and exams and all. So what study strategy works best for the resident? As you recall your resident time, like daily short reading, yeah, weekend bulk study, or exam-oriented prep.
Okay, in the first year, what you do is you focus on the basic things first. You focus on your X-rays, you focus on your image-guided procedures, and you focus on your ultrasounds. And start building up your anatomy for the cross-sectional imaging, which includes your CT and MRIs. Okay, be thorough with your X-rays, complete those in the first year, and then shift your focus in the second year to CT and MRI. Report as many cases as you can, be it the simple ones or the difficult ones. Okay, and start doing case-based learning. So you do one case in a day, okay, and which you think needs to be learned when you go back home. Study about that case, come back the next day, and then report it. Okay, so this is, we call it as case-based learning, because you cannot study all the theory in 3 or 6 months. Okay, it's a three-year program. Okay, so you have to divide it. So you have to study based on the cases what you see on day-to-day basis. Okay, and for the exams, you start in the third year. Okay, so before that, you should develop your skills first. Okay, skills should be based on theory. Okay, but exam-oriented teaching or exam-oriented study should start from the third year.
So the basic is don't skip the main textbooks. First and second years is to read the hard copies or the iPad. So the books have to be read by second year, and then start consolidating all the materials for your exam preparation in third year. That's how you use the time.
Okay, so in hindsight, what should resident worry less about, even though we obsess over it?
So getting confused between being able to report everything in the first year, you will not be able to report, or you may not get the chance to report MRI in the first year. So first of all, be at peace with it. You are not expected to do everything in the first year. As sir pointed out, divide. Start with the basics and then go on advancing. A case-based approach is best. So for a cholecystitis, now cholecystitis is a condition in which sometimes X-ray is done to rule out emphysematous cholecystitis. So you should know the findings. How does cholecystitis appear on ultrasound? Then CT and then MRI. So modality is not not telling you how advanced you are if you are able to report that. It's the disease. You should catch it at whatever modality you have at hand. So that is important. Don't get confused and read everything at your pace. Try to cover everything. Don't miss out. That's it.
So how can residents balance long reporting hours with studying without burning out early?
So again, this will be done if you have very clear mindset. You have said, say, you want to read 3 cases, 3 typical or different cases in a day. So if you're doing cases day on day basis, at some point you will be able to cover your demographic area. Then you will start saving on time. So that is how you plan your study. Take time for your health. Do join a activity or gymming or whatever you like. So physical activity is very important part of residency. Otherwise, you will end up gaining weight. You become lazy and you will lose interest. Pick a hobby. That also needs 1 hour of your day. So keep balancing everything and don't skip on anything. Reading is as important as doing your hobby. So that will help you not burn out in the end. So I think that's the best approach.
So how much importance should residents give to the exam scores versus practical competence?
Practical competence is the utmost important. Okay, exam scores will end once the third year ends.
Exactly.
Practical competence will help you throughout the life. If you're not practically competent, but you know almost 100% of the theory, you will not be able to survive in the practice.
So first 2 years for your practical competency, develop all the skills possible. Third year to clear the exams.
Clear the exams. Cram it, clear it, forget it. Remember your skills.
Yes.
Okay, so at what stage should residents start thinking seriously about the subspecialties or fellowships?
The interest about any subspecialty you will develop once you start completing your second year. Okay. In radiology, you do not have many DM degrees. They're mostly fellowships only, which are available for most of the subjects. It's just there is intervention radiology, we have DM degree. Rest like MSK, fetal medicine, cardiac radiology, we have fellowships only. Okay. So the duration for these fellowships is just ranging from 6 months to 2 years. Okay. So even if you develop interest in the late second year or in the early third year, you can decide upon that in which subspecialty your interest is there, and you can pursue that fellowship in that subspecialty.
So basically, most of the people who are very intelligent, they get intuition that I want to be a fetal medicine specialist or something. But I think 90% of the people are not very clear, especially those who take radiology. Again, most of people who are taking radiology are not taking because they love radiology. They are taking radiology because they get radiology. And I believe everybody would agree to that. So radiology is something which we don't get exposed to in internship. So once you get a good rank, you choose radiology. Same way, you complete your residency, pick a senior residency at a good place, work with all the subspecialties, and then choose, rather than getting confused at the end. So for me, I liked OBGY, but I did not like OBGY, the practice. So after doing radiology, I took fetal medicine. Same way, most of the people, if somebody asks me, now first year residents want to know where to do fetal medicine fellowship. You're doing first year and you want to do fetal medicine fellowship straight away from third year, no. That is not the right approach. Join a senior residency at a good government college or where patient burden is high, and then choose what you love. So if you like something, then specialize. Otherwise, general radiology gives a lot of financial stability and satisfaction. So you get a lot of work from general radiology also.
But one thing you need to remember that in the Indian market, still now, the subspecialties have not taken over.
For radiology.
For radiology. Okay? You cannot say that I'm a MSK specialist and I will only practice MSK radiology.
No, you can't.
You cannot survive. Okay? You need to know the general radiology also, and you can specialize in some branch, okay, that you know more about that branch. But you have to remain connected to the general radiology to survive in the market.
So that is an advantage of radiology. You need not subspecialize. You specialize only when you feel like it. There is no requirement of doing it.
It only helps you to differentiate from others.
Yes.
Okay? That's the only purpose of subspecialty.
So the same question, like you have answered, like, did doing a fellowship significantly change your career trajectory, or could you have reached the same place without it?
So doing a subspecialty helped me achieve something which I really loved. I loved fetal medicine. I'm practicing it and I'm at peace. I'm satisfied. So that is one thing. However, if I had not subspecialized and I was just doing general radiology, still fetal medicine cases would come to me. So it has not significantly altered the career pathway or has increased the financial aspects of it, but it has just made me clear in concepts. Plus, since earlier I told you there's a lot of medical legal implications. So if you're short on knowledge, you might miss something which later can reflect on you. So if you are doing something as a specialist, or you are working as a one-stop solution for that particular problem, for example, if you're doing a fetal echocardiography, then you are expected to rule out everything end to end. In those cases, subspecialization will help. So it gives me immense pleasure and satisfaction doing what I love. So that helps.
And it has helped me to increase my bar of reporting.
Yes.
Now there are some subjects which are undertaught in the radiology residency, which are not focused upon. Yes, one of them is fetal medicine. Another is you can say cardiac radiology, musculoskeletal radiology. In most of the centers, the exposure to these subspecialties is very less. So the reporting in these subspecialties actually below par. Okay. So what this fellowship in subspecialty has helped me is increase my bar of reporting, which I could not do in the radiology residency because of the underexposure.
So the game is ultimately to be hand in hand with the clinician and help the patient. So specialization gives you the armor to solve the clinical question. And I think if you truly love a part of radiology, you should subspecialize.
Okay. So as compared to the other branches, like other branches have some subspecialties which are currently oversaturated. So is it the same in case of the radiology?
I believe, yes, there are a lot of fetal medicine specialists now out there. Yes, I think cardiac and MSK, as sir was talking about, less people take it because it's more time consuming and not as rewarding as fetal medicine is, because it is something which is required for all. But again, it is not as in other branches. It's not, saturation is not the real game now for radiology. So it is going to help everybody, because fetal is something which will, which every resident or every clinician or consultant, practicing radiology consultant needs to do. So saturation is not going to be a problem. Okay. So I think it's good now. The situation is better for radiology at least.
So which still offer a long-term value if you talk about the subspecialties?
So all, I think if in terms of AI taking over, so the perspective of intervention radiology is something which is as surgeons, because AI cannot take over your skills. Similarly, ultrasound is one in which your manual skills are involved. So long-term prospects of ultrasound and intervention is better than doing the rote chest workup or other reporting. I think that is something which requires skill.
Someone is just have passed the radiology. So is it better to become a strong generalist first or specialize early?
As sir said initially, that despite being a MSK specialist, he has to do fetal ultrasound. So in radiology, whenever you are joining, be it in government setup or in private setup, you are expected to do everything, starting from chest X-ray to MRI, knee, or MSK MRI. So being a basic, or I would say a good level generalist, will help you secure a position in a corporate or a good private setup. Over that, if you do specialization, that is for your professional satisfaction and some financial benefits. But again, being a specialist, you cannot say that I will not be doing that modality because I have specialized in this. You are expected to do everything. So being a generalist is most important.
It's just like adding another weapon to your armory. Okay. You cannot just go by your initial weapons. You're just adding one more weapon to the armory.
So reporting,
it's becoming more strong in reporting.
Yes.
But you need all your weapons.
So the same question from both of you, like we have heard, and you also heard, like AI gonna replace the radiologist and all. So what's your view on that? Is it real thing, or is it something different what we heard from so many people?
Okay, so my opinion on this is AI will be replacing those radiologists who are technologically backward. Okay, so we're not going along with the technology. Now, what we do is a radiologist can report almost 15 to 20 cases in a day. He has to type the cases, or he has to get it typed by somebody. So to reduce the redundancy, you can use the AI for that. So AI basically can make formats for you. So you can reduce the per time reporting. Okay. So the one radiologist who are not going along with the AI will get replaced, definitely with that. But radiologist as such as a whole will never be replaced, because the importance of signature is very much. Human mind has made AI, so human mind is better than AI.
Certainly, AI is going to help radiologists. So you have to be at par and apt. Learn AI and then help yourself.
Yes.
You are not competing with AI. You have to work hand in hand.
So we have seen
AI
on,
your companion.
yeah. So we have seen on social media, like just I think 1 or 2 months before that, AIMS has started their reporting from AI. Yeah. So what was that exactly?
So I also saw that post. Basically, the program, it is being done previously also. We have cancer screening programs for chest on CTs. So AI is going to look for major patterns. Basically, it is all pattern recognition, the deep learning system. So when you are, they'll generate a provisional report according to whatever they have screened, and a radiologist will manually then check whatever was picked is right or not. So that way, if you were going to look for everything, it is going to save a lot of time, because AI is already screened a lot of things. So that will save time, and manually still needs to be verified by a radiologist. So it has not taken over. The reporting is not done by AI completely. Still manual verification is required.
Suppose there are 100 chest X-rays to be reported. So what AI has done is AI will shunt out all the normal X-rays. So the radiologist has to look now on less number of X-rays. So he will be able to report those 100 X-rays in a less amount of time.
And focus more on the critical ones, the ones which require
more normal
attention.
ones.
So let's talk about the life after residency and long-term growth. Corporate radiology, private practice versus academics. What should residents realistically know early on before joining the radiology residency?
Each has its own trade-offs. Okay. So based on your lifestyle, like whatever you like, so you like teaching more, then you should enter your government hospitals. Okay. If your main long-term goal is income, then you have to enter the private practice. Okay. And if you want to balance both, then you can join a private center. Okay. So private center offers you the luxury of taking along the academics also, and the benefit of income as well. Okay. Corporates, they are more like focused on the numbers rather than quality. But in diagnostic centers, you can still focus on quality if you want. If you are opening your own center, so you can take as much time as you want to provide the appropriate quality report to the patient, and you can charge the appropriate income as well.
So the approach for a resident, say if I am a first generation doctor in my family and I've taken up radiology with no setup. So what should, if somebody asks me what should be the approach? So the approach should be, first join a government center or an academically oriented center. Get your thorough knowledge, basics, theory, everything cleared, and practice hands-on as much as possible, interventions as well as ultrasounds and scans. After that, join a corporate for good 1 to 2 years, then get a practice and achieve a balance between the accuracy and number. So you will get the time and you will get adequate number of cases. After that, to get the work-life balance, join a diagnostic center. By then you would have settled, married, kids. So now that's the time where you know your vision of life is clear and plan of opening your own center. That's the ultimate goal. So that's the timeline.
What actually determines the income growth in radiology, like degree, sub-speciality, location, or work ethic?
I think it's basically your professional reputation. Okay. So how much you are connected to the clinicians, because they are the ones who are going to send us the cases. Okay. So patients will not be coming to us on their own. First, they will go to the clinician, and the clinicians will refer to us. So your income growth solely depends on the professional reputation which you develop in the practice.
No, we do have a segment of patients, the Gen Z, Gen Alpha, and the smart people who are using ChatGPT, and they get an ultrasound done, and then they decide which doctor to go to save on consultation. So that's one segment of patients. I believe it's a dependent branch. I would not lie to my fellow new joinees who are having big dreams. It's a dependent branch. So you have to have a good communication skill. Plus having a overall knowledge and a good communication, good rapport with system will help. But being very brutally honest, there is nothing like exponential growth in finances in radiology. There's a very early plateauing. You might earn more than your peers in the beginning, the 5-6 years, but your surgeon and medicine friends, though initially slow, will make a good amount in long run, until unless you open your center. Then sky is the limit. So if you're planning to stay in a corporate or private setup for life, then accept the plateauing and be at peace. But if you want a lot of growth and a lot of financial rewarding, then you have to have your setup.
Okay. So how do you, this question is from both of you, like how do you protect yourself from burnout in high volume reporting environments?
Okay, what I've done now is I've defined my working hours. Okay, and I'm focusing on my physical fitness now. And you should not get disconnected from the academics, because whenever you're trying to report large number of cases, you get disconnected from the academics, and then you almost start working like a machine.
Yes.
Don't get to that point. Okay? Define your working hours. Remain connected with your academics. Okay? Keep the interest in radiology ongoing.
And the habit and the hobby that you picked in your residency will help you, avoid the burnout later on.
Okay. So what single skill or mindset helped both of you grow the fastest in your first 5 years of your practice?
Treat every scan like it's yours.
Yes.
Okay? So I treat that. So I take the ownership of each and every scan I report. I report it like as I'm reporting on my own. The same confidence, the same determination, okay, I put in every case.
And you have to take history. You have to correlate. Just writing clinically correlate will not help. You have to do that clinical correlation part and help the patient along with the clinician. So work as a team. That is important.
Okay. So let's talk about life of both, like your as a professional or as a personal, like a couple and personal dynamics and all. So some profession, the same profession and same branch. So how did you support each other during your tough phases?
So everybody has their own weaknesses and strength. My strength was the women imaging and fetal parts, and his strength is anatomy, so musculoskeletal. So we used to delegate each other the tough cases and save time. So that was one thing which helped a lot. And the second thing is discussing. So you have different opinions, different thought processes of dealing with a case. So discussing helps a lot. Why is this a possibility, and how can we make it, how can we rule out the other things? So definitely discussion helps a lot.
We try to complement each other.
Yes.
Okay? Not compete with each other.
Hopefully.
But sometimes the argument will happen. Yeah,
Definitely.
already. Yeah. So did you ever disagree professionally on reports or decisions, and how did you handle that, both of you?
We always discuss the facts, not the egos.
Rational is above all. And most importantly, I have accepted that he knows MSK very well. So I don't discuss or don't fight. I take his opinion rather in those cases. And he does the same for fetal medicine. And that's how you complement. When you have friends who are doing different subspecialties, you take their opinion and you have the history, so you can put everything in place. So that's going to help. So again, it's a teamwork.
So one thing you admire most about each other as a radiologist, not as a spouse?
Clinical clarity.
Yeah, I believe he's really hardworking and has a great depth of knowledge, which he tries. The effort he puts behind every case is commendable.
Okay, so who was more stressed during residency and who hides it better?
I think Dr. Gursimran was a little more stressed than me. He used to show it. I am the one, my lid goes off if I'm really stressed, so I forget it. That's how. So I don't take much stress. So do your best and leave rest to the God. That's my principle. Leave the rest.
Okay, so looking back, what do you do differently if you were starting radiology residency today? Same question from both of you.
I would have focused more on depth rather than comparison. Okay, so in my residency, I was more stressed about comparing with others, what others are doing. Okay, so kind of like a rat race. Okay, but in hindsight, if I would start again, I would focus more on depth, more conceptual clarity, okay, and less stressed about comparisons.
That's an advantage that I had being first-gen doctor. I had no one to look up to. I was carving my own path and I was really happy and blissful about it. So the only thing that I feel I could have done better is read more anatomy, and that should have started in first year. So that's the only thing. Otherwise, I had a beautiful journey in my residency and I really love every aspect of it.
Okay, so if a resident wants to know, be genuinely good in the 5 years, not just for the employment and all, what should they start doing from day one?
You cannot miss your anatomy. Then you have to be consistent. And third, you have to be accountable for your mistakes, reflect on your mistakes, and do not repeat those mistakes.
Yes.
First time mistake is acceptable. Repeating the mistake is not acceptable. You have to learn from your mistakes and then improve upon those. You have to start this from day one.
And as a resident, not for radiology, for all the branches, doctors are humans and you need to achieve a personal work-life balance. That is important from the first year itself. So you need to pick a hobby and do something in addition to your profession, be it for 15 minutes, 30 minutes, whatsoever as time permits. But it needs to be inculcated that from the very beginning, we are not just robots who are working. You need to have a personal space and personal time for yourself. And as you grow, like over 5 years, 10 years, you tend to get bored of doing same thing repetitively. So you have to have a hobby that helps you out. So achieve the work-life balance right from the residency.
So one honest sentence from both of you for a radiology resident who is quietly struggling right now.
If you're feeling lost, it doesn't mean you are failing. You are actually learning. Okay, so it's okay to be lost.
And from my side, you are not alone. In radiology, being such a vast subject, you are almost reading all the 19 subjects again. And in addition, you are learning modalities. So it's very vast. So don't forget, now as a community, we have come up and everybody is helping out each other. Especially Salaah Shots is doing great work. So whatever terms you are confused, you can always reach out at any platform and seek help. There's no fun in keeping quiet and thinking just about it by yourself. Reach out, take help, and grow.
Okay, so now we'll start our rapid fire round. You both have to answer the same questions and with one single sentence. So the first one is, one mistake every radiology resident should avoid.
Don't avoid the difficult cases.
Skipping anatomy.
One habit every resident must build.
Daily anatomy review after each case.
I think, again, reading daily. That's very important.
One myth about radiology you want to break.
It is not easy. It is not relaxed.
Radiology is not equal to money.
One thing you wish someone told you in the past.
Confidence comes after competence. If you are competent, confidence will definitely come automatically.
The moment you get radiology, life is set. It's not.
Okay, so radiology is a branch where you don't touch the patient, but your words touch every clinical decision. Today, we didn't just talk about the scans, machines, or reports. We talked about the confusion, mistakes, confidence, and burnout, growth, and purpose. To every radiology resident listening, if you feel slow, lost, or unsure, you are not failing. You are forming. And to Dr. Gursimran and Dr. Ekta, thank you for sharing not just knowledge, but honesty and heart. So if this episode helped you even little, share it with one resident who needs it, because guidance would travel faster than confusion. So this is Dr. Sagar Pushp, and this was Salaah Shots podcast. So stay curious, stay kind to yourself, and keep growing. You are not behind, you are under construction. That's exactly where growth begins. So thank you, both of you, for joining today's podcast, and all the best for your journey, and hope you both going to help the society in different ways.
Thank you.
Thank you so much, sir.
Thank you. Thanks a lot.